There's an awful lot to say about functional neurosurgery, both what's happening now and potential for the future. So I cannot claim that this is a complete, comprehensive review, but I hope you'll find it to be a useful snapshot of what's going on in the field and a source for future discussion and ideas. So advances can be divided into several categories. You could talk about disease states, but I'd like to talk about work that's going on the technical, technological, and clinical ends in functional neurosurgery. But as with everything in medicine, or really in life, certainly in neurosurgery, but I think especially in functional neurosurgery, we have to beware of overstated assumptions and premature conclusions. And I may come back to that theme several points during this talk. So technical advances, really I'm referring to modifications of current existing technologies. So most of what I'll talk about today is related to DBS, and again, that is only a part of functional neurosurgery, and I'll talk about lesioning as well. But we could do DBS perfectly well with this sort of traditional method, and this is how you could see me doing it here. The patient with Parkinson's disease, I'm standing on the side with my arms folded. I guess something was making me a little unhappy at the time. But patient has a CRW, stereotactic frame, and there's a C-arm position, and patient is awake with microelectrode recording and so on. And that's a perfectly excellent way of doing that surgery. But how can DBS be improved from the technical end? Well, one way is harnessing advanced intraoperative imaging. I mean, all a fluoroscopic C-arm will tell you is the relative position of your electrodes at the time. But if we could do sectional imaging during the surgery, we can know what we often wait until after surgery, namely, where are our electrodes exactly? And in fact, you can perhaps bypass the need for awake mapping and even awake electrophysiology doing the surgery this way. So this technology was developed for intraoperative MRI use at University of California, San Francisco. This was not for an MRI in the OR. This is turning a diagnostic MRI into an OR temporarily, and this has been commercialized, the technique called ClearPoint. And if your goal is to get your electrodes in to the subthalamic nucleus, well, you could just see that you're in the STN and you're done. And that's the advantage of that. And in this first report from UCSF, they did find that in almost half of the patients, they changed their electrode position based on intraoperative imaging as opposed to waiting to have a problem afterwards. And in this more recent report from China, it's very interesting that they actually combine technologies, because as opposed to in that original report from California where the patients are operated on asleep, here the patients were awake. So they combined traditional clinical physiology as well as microelectrode recording and macro stimulation during the surgery together with intraoperative MRI. And if you look at the numbers here, in slightly over a quarter of the electrodes placed, there was a change in the position. And interesting, most of the time, the error in positioning was to the right. So if you look at these examples on the upper images, you could see these electrodes are too medial, in this case, too anterior, and then they're replaced based on the intraoperative MRI, boom. No anxieties after surgery. Do we replace the electrode or not? You are in position. Really an outstanding use of intraoperative imaging for this purpose. It turns out you could sort of accomplish the same thing using intraoperative CT. This work was pioneered by Kim Burchell in Portland, Oregon, and has been expanded upon by Frank Ponce at the Barrow Institute in Phoenix. And of course, with a CT, you don't get the direct imaging quality you can with intraoperative MRI, but you can obtain an intraoperative CT, merge that to your preoperative MRI, and from that, you can assess the position of your electrode in its neural anatomy with pretty much the same reliability as you can with intraoperative MRI. The thing that I find curious here is that the electrode was moved in only 1 out of 119 instances, so it calls into question the whole need for the intraoperative CT if your electrode placement is that good. Certainly the general experience around the world is that electrode placement is not quite that accurate, and that's where the benefits, the technical advance of intraoperative imaging would be better. So that's the electrode placement. What about making the DBS itself better? Right now, the standard DBS system, primarily made by Medtronic with a couple of other competitors coming online, it's a dumb electrode. You put it in, it has 4 or more contacts, as I'll say in a second. You leave it on pretty much the whole time, and you can adjust the stimulation field, but that's all that it is. It doesn't respond in any way to the physiology of the brain. But just as has been done in the cases of epilepsy patients to have closed-loop stimulation, you can do the same thing theoretically with patients having DBS for movement disorders, pain, psychiatric conditions, or what have you. And this is work done recently in Oxford under the leadership of Professor Aziz. And this is all experimental. So these were not implanted systems, these were externalized systems. But they found over the course of 3 days of monitoring in the ICU with these externalized systems that the motor responses contralateral to the electrodes were better when a closed-loop system based on physiological feedback was used rather than simple continuous stimulation. Undoubtedly, this is going to be a standard in the future. Another way to modify the DBS, there's a limit to how you can shape the stimulation field at this point. Monopolar stimulation is better for efficacy, bipolar stimulation is better for side effect avoidance in a very small nutshell. And you can adjust the stimulation, you could choose different contacts, different combinations of monopolar and bipolar and stimulation output, etc. But really that's it. And if your electrode happens to be a little bit off, you're stuck. What about having a smarter electrode? And there are 2 groups in Europe that have been actively working on this, using more electrodes that can be programmed in different ways to shape the stimulation field better. This is an example in a non-human primate from the previous group, as you could see, where you can have dramatic changes in the stimulation field just by changing your stimulation geometry. And this is another group from a more recent paper in the Journal of Clinical Neuroscience from Holland. And the cartoon illustrates what you can do. If you look on the right, this is an example of the problem. If your electrode is a little too lateral and you're stimulating the subthalamic nucleus, you will be stimulating the corticospinal tract, and you will get contralateral motor side effects. That will limit the efficacy of your stimulation. And your only choice at that point is to accept side effects, no good, less efficacy, also no good, or to replace the electrode, also not great. But if you could shift the stimulation field just a millimeter or 2 medially, the problem is solved, as the left side of the cartoon illustrates. This too is going to be a standard in DBS. Now, lesioning has gotten a lot of attention lately as a way of sort of going back to the future and avoiding some of the expense, complicatedness of deep brain stimulation technology. And I'll get a little ahead of myself and say I think some of this enthusiasm for lesioning is a little bit overstated, but there is a lot of activity going on, even to the extent of using subthalamotomies. You know, we're trained that a lesion of the subthalamic nucleus causes hemibolismus, and as you can see in this paper from Cuba from several years ago, that risk was not trivial. 1/6 of the patients had contralateral hemibolism, and 8 of them needed pallidotomies to relieve them of that, and the efficacy of the subthalamotomy was limited. They had an initial response with a decrease in their abnormal Parkinson scores, but those scores did increase over time. And this paper, another paper by Rick Sherman from Holland, compared, this is really the only paper that compares DBS to lesioning, looking at patients with tremor, whether they had Parkinson's disease, essential tremor, or multiple sclerosis. And it's interesting that efficacy over an up to 3-year period is pretty much the same whether the patients had DBS or a thalamotomy. So that's pretty good. That's an argument for thalamotomy. But if you look at complications and side effects, unsurprisingly, after several years, those side effects remained higher in the patients who had lesioning. In other words, they did not recover fully from the side effects. So there's a reason DBS became popular 25 years ago. That's because it's good and because you do tend to have fewer side effects. Nonetheless, there are technological advances that make lesioning a potentially more attractive alternative, and one of those in particular is laser interstitial thermal therapy, or LITT. And what it is hyperthermia. And we should remember that. There's nothing magical just because it's the laser. You know, that always sounds sexy and science fiction-y, but that's what it is. It's treating with heat. And heat's been used for decades in neurosurgery, and it still is used using radio frequency. There were other studies using microwave heating. There's a parallel effort of a non-invasive treatment using MR-guided focused ultrasound or high-intensity focused ultrasound. I'll mention that a little bit later on. But laser energy is uniquely compatible with an MRI environment, and you can get real-time feedback with what you're doing as a result. Visualace was a startup in Houston, acquired a year ago by Medtronic. This is one of the 2 commercially available LITT systems that I know of. It's the one that I personally and my colleagues have worked with in our system. And this is a schematic illustration that shows how it works. The laser has to be surgically placed. You could do that in an intraoperative MRI or in the OR. And then in a high field MRI, you have feedback between the computer and the laser that sit outside the MRI with a cooling system of some kind to prevent scarring and control where the heat goes, and the patient and the laser in the MRI itself. And this is a GIF of a patient who had a brainstem metastasis. This was not for functional purposes, but it just shows what it actually looks like on the real-time video as you're growing the hyperthermic lesion. And LITT has become, perhaps popular is not too strong a word, but a good alternative for treating patients with mesial temporal lobe epilepsy to avoid, especially in people who have dominant temporal lobe epilepsy, to avoid the complications of resection from that surgery. And here's a study from the University of South Florida in Tampa, which showed comparable clinical outcomes, both in terms of seizure relief as well as neuropsychological outcomes in patients who are having LITT or resection, with decreased length of stay, unsurprisingly, in the LITT patients. So we've operated on 31 patients with epilepsy so far, primarily mesial temporal lobe, as you can see here, with really excellent seizure reduction outcome in 1 year, 50% seizure-free, and another significant percentage who are nearly seizure-free or not having generalized seizures anymore. So I mentioned MR-guided focused ultrasound a little while ago, and this also is a technique that uses hyperthermia for its results. There's a small degree of cavitation involved, but for discussion purposes, it's primarily another hyperthermic technique, and its attraction can come from the fact that it's non-invasive. At this point, it requires the use of a stereotactic frame, and focused ultrasound has been attempted for decades. The reason that this has gained excitement is because recently, for the first time, there's technology that allows the ability to focus using several hundred miniature transducers to focus through the skull, and in a manner that mimics how radiosurgery works, generate heat at a small point within the skull. The problem is it only works for a small envelope within the diencephalon. So if you want to treat the thalamus or the basal ganglia, you could do that. If you wanted to treat targets outside of those areas, the temporal lobe, extratemporal epilepsy, at this point focused ultrasound is not going to work. Nonetheless, like LITT, you could see where and when you're putting your heat lesion at the time, and that's what makes it attractive. And this was a phase 1 study from the University of Virginia showing how you can create very sharp lesions within the ventral intermediate nucleus of the thalamus and relieve tremor, as these reduction in tremor scores show. There's now a phase 2 trial going on, as well as a phase 1 trial beginning for patients with tremor predominant Parkinson's disease. So this is a technology to keep one's eye upon in functional neurosurgery. Now, clinical advances really have to do with different ways of looking at existing technologies and techniques in functional neurosurgery. So one question is, what about the timing of DBS for Parkinson's disease patients? Typically, we wait till patients fail their levodopa, they have increased medication requirements, they have on-off fluctuations, which are very distressing and uncomfortable for patients. They have dyskinesias because of their increasing medication requirements. That's when typically they're referred for DBS so as not to expose them prematurely to the risks of surgery. Well, what about stimulating patients earlier? This study from Germany, which was published a year ago in the New England Journal, showed that if you treated patients after several years of levodopa, as opposed to waiting longer, their results were as good as if you waited the more typical 10 or 12 years. What it did not do was show that there was any protective effect to early stimulation, and that's still sort of a hope or a holy grail of Parkinsonian DBS. But this is a trend that's probably going to become increasingly common in the next decade, which is to have patients with Parkinson's disease referred earlier and get DBS surgery earlier rather than waiting for them to suffer the complications of levodopa. Now, what about psychiatric neurosurgery? Now we're getting into a little more controversial waters. There's a lot of excitement 8 years ago when first PET and then functional MRI studies showed that there was sort of a marker on metabolic and functional studies for depression. So this work from the University of Toronto showed that there was hyperactivity in the subgenual area, so-called area 25, and that if you stimulated those areas, you could reverse the hyperactivity and get clinical improvement of depression. And that was in a preliminary trial. Unfortunately, an open-label trial, a multi-center trial, really found that there was no truly significant improvement in depression on those patients, and that work for that particular area is on hold. This does not mean that we cannot treat patients with medically refractory depression with neuromodulation, with electrical modulation. Undoubtedly we can, we just need better science and a better target. Similarly, this work in the ventral striatum, the anterior internal capsule, and the nucleus accumbens, led by Ali Rezai at Ohio State University, initially showed a good response in 50% of patients, but then again, a multi-center prospective randomized clinical trial did not really show significant improvement. So the question is, would an alternate study design work or a longer blinded period? In any event, that work as well is on hold. And the question for neuromodulation with depression also remains, well, what about other targets, like the medial forebrain bundle, which has been proposed by Volker Koenen in Germany, or the dorsolateral prefrontal cortex, which was stimulated in a preliminary study by Imad Eskandar at Mass General Hospital. So this is all preliminary work, very much in progress in psychiatric neurosurgery. We know that surgery for patients with obsessive compulsive disorder works. And in fact, lesioning and DBS seem to be equivalent. And if you go back to the earliest days of psychiatric surgery, going back 70 or 80 years ago, in retrospect, they were talking about patients with OCD, or what we would now call OCD, who benefited the most. So what about DBS? As you can see here, multiple targets have been looked at: the anterior limb of the internal capsule, the inferior thalamic peduncle, even the STN, with measurable and even significant reductions in their Y-box, a Yale-Brown obsessive compulsive score, in most of these small series. However, this was the conclusion from this paper, senior authored by Bart Nutan at Leuven in Belgium, who's really probably the world's authority on this topic. It's still experimental. So we have to approach all this with great care. And that's true even if we're doing lesioning, which has a longer track record. It's interesting to see how the results are either equivalent or even better than DBS from Mass General, which has a 50-year track record of doing this kind of surgery. And as you can see here, most of the patients, if they're followed long enough, do have a significant reduction in their obsessive compulsive behavior as measured with the best objective means possible with the Y-box score. I just want to put in a note of caution for anyone who wants to apply radiosurgery in functional neurosurgery, especially for psychiatric disorders. The potential for complications is not trivial. I took care of a patient who was treated in such a trial, a very carefully controlled study out of Brown, and he developed these bifrontal cysts. So initially, he didn't need anything done, but then he presented with obstructive hydrocephalus and responded to a shunt, and he was okay. But then, as you can see, this left frontal lesion expanded, he herniated, got a Tourette hemorrhage, required that lesion to be removed, which turned out to be an organized hematoma 5 years after the gamma knife, and isn't doing so well as you would think. So be careful before you try stereotactic radiosurgery for functional neurosurgery. Tourette syndrome sort of sits on the border of psychiatry and neurology, and this paper by the late Robert Masunis was really an example of how to carefully assess these patients. Multiple video clips of their tics. The clips were chopped up in time and scrambled and rated by blinders. And they found that 3 out of the 5 patients had a significant reduction from centromedian thalamic stimulation. So there have been a lot of papers about DBS for Tourette syndrome. And if you look at them, they're all single-center, small retrospective studies, which is okay, but there are 8 different targets on these published studies. And all that means is that we still don't know what a good target is for Tourette syndrome. More work in progress. As far as schizophrenia goes, schizophrenic surgery is probably what led to the backlash against psychiatric surgery 40 years ago, and we're not ready to go there. That's Walter Freeman doing one of his infamous ice pick transorbital lobotomies. And as you can see here, scientists are trying to develop rodent models of schizophrenia. Now, you tell me how that's supposed to work. Are you supposed to tell if your rat is hallucinating or hearing voices like the cheese is in the corner or something like that? Schizophrenia is also not ready for psychiatric surgery, but stimulation for aggressive behavior perhaps is, and that sounds very controversial. Is it political mind control that we're aiming at? But you have to look at the patients in studies like this. Again, small single-center studies. These are really sick, dysfunctional patients who cannot be cared for by their families. They can't even be cared for in institutions. They're constantly rageful and violent and so on. And it appears that stimulating the posterior hypothalamus in carefully selected patients leads to significant improvements in their behavior and a calming effect. And this is something that we should take seriously and continue to explore. Eating disorders. Anorexia is a life-threatening condition, there's no question about it. It correlates with depression and OCD to some extent. And in this small study from China, there was an improvement in the basal metabolic rate of the patients who were stimulated. These were the inclusion criteria for this study. Dr. Nutan, whom I referred to earlier, suggested these criteria. I don't mean you to read these, but this is the kind of careful control you need in any kind of psychiatric neurosurgery study. The patients have to be selected and followed with the utmost of care, and that includes eating disorders. And what about obesity, which is the flip side? A pilot study from Allegheny University in Pennsylvania, where they stimulated the lateral hypothalamus, and they did find that 2 of the patients had a reasonable amount of weight loss, and yet it didn't correlate with a change in their resting metabolic rate. So the significance of this is not entirely clear, and my colleague, Dr. Taira in Tokyo, suggests, well, maybe people who are obese should eat less and exercise more and lose weight that way. In any event, there's a consensus we have from the World Society for Stereotactic Neurosurgery. You can read it in JNNP about careful guidelines for psychiatric neurosurgery. It has a role, but we have to advance carefully. So I got a few more slides.
Okay.
For epilepsy, many targets have been attempted. as you could see here, but there's no question that electrical modulation of an electrical disorder works, and for sure closed loop stimulation makes more sense for this than just about any other condition. And undoubtedly it works if you look on the bottom graph here. Significant reduction in epilepsy with patients with this commercially available closed loop stimulation system. To sort of finish up here, surgery for memory enhancement. This was a proposal by Bengt Linderoth from the Karolinska Institute using a biological approach. No clinical results yet, as opposed to the electrical approach suggested by Professor Lozano at the University of Toronto, which has not yielded great results clinically so far, although the functional imaging suggests its utility. And I just want to say a few words about the potential risks to neurosurgery. The BMI was developed by neurosurgeons almost 20 years ago, but because of advances in electrophysiology, it can become a non-neurosurgical technique if we don't look at the non-invasive aspects of it seriously. It's like radiosurgery. It's a neurosurgical concept. We need to manage it, to advance it, even if there's no actual cutting involved. Transcranial magnetic stimulation, again, this is a paper from Harvard Medical School where they're using navigation and functional MRI and to stimulate patients for pain, and it's been done for depression as well. They talk about the risks of DBS and why TMS is better. This is something that neurosurgeons should be doing. So get a TMS unit in your center and start to use it and to publish. And we need to be flexible for non-cranial applications of what are considered traditional cranial diseases, such as Parkinson's disease. So it turns out, when I was talking about the concepts of we need to have knowledge of what we're talking about, flexibility of new techniques, we need to be scientific in our approach, and we have to be honest about methods if they don't work. Well, it turns out to mirror the acronym of one of the hosts of our meeting, the King Faisal Specialist Hospital. That turned out to be a coincidence. So we have obstacles to overcome in functional neurosurgery. Our technology, as sophisticated as it is relatively crude. We have to have better technology, better science of brain physiology. The techniques will not just be limited to DBS, as excellent as that is, and many more people will benefit from intracranial stimulation, and it's just a really exciting time now in functional neurosurgery. Thank you.
Thank you so much, Professor.